lead is Louise, who's also online. Welcome to our first Zoom session. We're very excited. And we want to say a big thank you to Matthew for helping us organise today. I think everyone's got themselves on mute. If you don't, could you put yourself on mute? Just it helps things run a bit more smoothly. We'd really welcome participation and questions throughout. So as soon as you have a question or a point to raise, just put it in the chat or raise your hand. And we'd quite like to hear about you and who you are and where you're from. So if you want to put that in the chat and why you're interested in AI, I prepared my bit so I can start it off. There we go. So I know the invite has gone out to members beyond the special interest group, so I'll just give a little introduction. The Q Community Digital SIG is about opening up new challenges and opportunities for quality improvement, bringing analytics and methods into improvement settings and improvement methodology into digital projects. So now over to Dom to hear about NHSX's work with AI and the challenges and opportunities for quality improvement there.
Thank you, Rachel and Louise and Matthew for inviting me to this session. And it's really nice to see some familiar faces, or familiar names. I can't see everybody's faces. So on today's session. And look, I'm going to present some slides, just give you an overview of what NHSX is doing, specifically on the NHS AI Lab, and then some bits around some of the work I've been doing during COVID. And I really just want to make sure that this is a conversation and not just me monologuing. So those of you who know me, I can monologue for quite a long time, but it's going to get pretty boring pretty quickly. So feel free to interject, put stuff in the chat, or unmute yourself and ask me questions as we go through. And I'm really interested in this conversation about what does this mean? What does AI mean for healthcare improvement and quality improvement? So let me just share my screen 1 second. See if this works. Present. Hopefully you can't see my emails. Yeah, okay, everybody, it's loading. This is, let's see what's going on. Okay, so we should start. So look, like I said, this is a conversation, so feel free to interject at any point. I'm Dom Cushnan. They gave me, so I joined NHSX in January of this year, but I've been in healthcare for the last 5 years doing various types of improvement work, which is why I know the guys at Health Foundation and the Q Community work, and really interested in this digital SIG. And before that, I ran a technology company specializing in computer vision, and done a few other kind of interesting things. But I'm really interested in how do you get the safe adoption of technologies into healthcare? And I'll talk a little bit about that and how we're doing that in the lab. You know, when I joined in NHSX in January, they did give me this random title of specialist advisor for AI and digital health. But I'm not a titles person at all, and I'm just Dom. So really about just kind of getting a conversation started, convening with colleagues and friends to look at addressing some of these thorny issues that we're trying to do, and really do the doing. I think is probably the important bit. Like, how do we get out of the academic conversations and start implementing stuff and taking some of those lessons? So we'll go through that. So the AI Lab has been set up. It was announced last year. We received our funding this summer to look at the acceleration of the safe adoption of artificial intelligence in healthcare. And before I kind of move forward, I just wanted to, that slide is not going to load. Let's see if it loads up if I do it this way. It could just be that image is too big. Can I just get a show of hands or a comment in the chat box about who has read the NHS artificial intelligence document on how to get it right that was published last year? Let me see if I can open my chat. I think so. Okay, so let me let me highly recommend going to have a read of that. So that basically gives an overview as to our definition of AI and also some of the case studies of current work that's going on in healthcare. So let me see if I can come back into this to go full screen. I'm not sure why that slide is not loading. But I think we can ultimately agree that there are a number of issues when it comes to implementing data science or informatics in healthcare, and when we want to do advanced analytics or badged as artificial intelligence. There's a number of key issues that are quite clear about how we do this, and we're here to help facilitate some of that. So in terms of regulatory responsibilities and pathways, we did an exercise last year with an organization called Reform, who did a piece of research looking at the regulatory landscape and some of the confusions and the kind of ultimate Venn diagram that we always find ourselves in various institutions and bodies, and how do you get your technical innovations deployed into healthcare is kind of one of the key challenges. So we in the lab will be addressing some of that through our regulatory work. There's also issues around literacy, and I know that Health Foundation have been doing quite a lot of work on this themselves and have been handing out some support and work for helping organizations get their heads around advanced analytics. Then things around like how do you build public trust, and how do you go about the stuff I'm interested in, like how do you go about validating whether an AI model is actually safe to use, and how do you then scale that up? And we can come on to these in a little bit more detail as we go through. And the lab sits across all these key pillars of not only creating the environments, doing research on like what are the appropriate tools that we need for regulatory work. How do we then accelerate the adoption? And I'll keep talking about adoption because I think this is probably one of the most complicated bits of how do you get a model deployed across the healthcare system, and how do we help our colleagues understand what it is that AI is and how can we use it and when is it appropriate to use? And fundamentally, how do we make sure that whatever is being used is safe, and how do we do that post-market surveillance of when you've deployed a technology and its appropriate use? Our key programs, so the lab over the course of 3 years is to look at a number of key objectives, key programs. One is the AI and Health and Care Award, which is an award over 3 years with a roughly budget of about £140 million, supporting innovation and organizations who are trying to implement AI, create the right amount of evidence that is needed for deploying their algorithms, but also addressing some of the strategic aims of the long-term plan. The one I did touch on was also the regulatory ecosystem. I'm not going to read out all the stuff on the slide because you can read it yourselves. The regulatory ecosystem. So how do we get the regulatory bodies to come together and join up as a single multi-agency advice service to support both healthcare research and also healthcare providers understand like the landscape and navigate through that. We also have 2 other ones which are worth looking at, which is the Accelerating Detection of Disease Program, multimorbidities, and another piece which is looking at skunk works, like how do we build up a team of data scientists to address some of those issues around adoption and bits and pieces. And I'll come back onto some of the work we're doing during COVID. Any comments on this point before I kind of move on? Feel free to unmute yourselves. Any questions about the lab or?
Dom.
Yep, go for it.
Hi there, Dom. It's Mark Lomax here.
Mark,
the AIC was going to do sort of a competition to get entry into the AI lab, and then it's all gone quiet for COVID. Is there a time scale for that to come back into happening, or what's the latest on that?
Yep. So for context of those who are not familiar, so we did an exercise at the start of the year, which went out to market asking for people to apply for some money, and there was some slow delays just due to COVID and capacity back into the organizations. We are expecting announcements in August for that program in terms of who will be receiving money and where they're up to. And does that help? I don't know if that answers your question or.
It does. It was very quiet, and I don't know if that was just we hadn't been selected, or it was sort of nothing was happening on there, sort of on your side. So good to know it's moving forward, Dom.
Yeah, no, it's moving forward, and for those of you, just to give wider context for those who might want to apply when we reopen this up again later on in the year, the plan is to open this program up every twice a year over the next 3 years to address some of those big questions about artificial intelligence, and it's broken into kind of 4 key components: initial research, getting some ideas developed. And then what we classify, so that's kind of phase 1 to 3, and phase 4 is technologies that have been being used, and how do we create further evidence and help them work through some of the regulatory landscape, and that could be things like national screening programs or other bits and pieces that we can address. Does that help, Mark? I'm happy to take other questions.
Yeah, no, that's brilliant, Dom. Very helpful. Thank you.
No worries.
Tom, I have a question.
Yeah, keep going. I love it.
So for the AI lab, is it about funding projects or is it about mentoring projects as well? Because you may be in a really fortunate position where you've got funding secured, but actually you just need a bit of help navigating the landscape and getting some technical pointers.
It's both. It's absolutely both. So, I think one of the things, and I'll talk about the buyer's guide in a second, but ultimately what we want to build is a knowledge repository of how do you kind of navigate some of this, which is why we're supporting the regulatory bodies to come together to, understand that landscape, so you do navigate through it when you're wanting to deploy or buy or build. It's kind of that ongoing question. Does that help?
Yep, that's great. Thanks.
Question also, Dom, actually, as well. Sorry, is it this funding? Is it possible to use that to help build a team?
I missed that last bit. Funding to do what? Sorry.
Is it possible to use the funding to help build up a team?
I've lost you completely, but I think I understood it to be build a team. Yeah, I think I'm getting thumbs up that might have been the question. This is primarily focused on innovations themselves versus building teams. I know that Health Foundation have done some work around supporting increasing technical capabilities inside organizations. But this particular fund is on research and innovations themselves. That's not to say that you can't work with an innovation and build a team around it and put that into your funding, but
Thank you.
Does that help? No worries. Was that Ben, was it?
Yeah.
Yeah, okay, brilliant. Good to see you, Ben. So let me come on to this next bit then. We've a 3-year program, and then COVID happened, right? So COVID happened, and then everybody that has a AI technology or some form of data science or will badge themselves as AI decided that they could help, right? Help the healthcare system. And one of the things that we kept getting specifically in my inbox was, can we use this AI technology company? Why can't we use this technology company? All these kind of like, how do we actually buy this technology? So we accelerated a little piece of work to address that question, just really to go back out to organizations to say, if you want to go on buy technology, there's a number of considerations that you would need to think through. And look, if you've bought technology before, it's quite similar to that. There's a number of standards that people need to meet. There are a number of considerations in terms of, an AI is for life, not just for Christmas. You need to think this through, and we've got a checklist for that. We went back out and kind of asked a number of considerations as to how can we expand on that, to go into a little bit more detail. What are the type of documents and what are the type of things that you might want to think through if someone was coming to you as an organization to offer their wares, so that you feel confident enough to buy that. And that's really kind of the first step in just getting that conversation, that slower conversation about what is it that you're buying, so you can make an informed decision. I would highly recommend having a look at that, and I welcome feedback and comments as we build this out. Does anybody want to come on to that at this point? Yep. And look, this is very much around like some of you guys will know this because I know some of you on the phone. So, how do you identify the problem? Are you doing the appropriate assessments? Are you creating the right evidence? Does the company have the right evidence? And making sure that you have the right procurement processes in place for buying your solution as well. But I won't go into too much detail on it because it's worth having a look through. That first document is not that big. It's about 10 points, 10 questions for you to consider. Any questions at this point before I talk about some of the work we'll be doing during COVID? I can't see the chat, so if there is questions, feel free to shout them out, Rachel or Louise. Okay, so the AI Lab's mission is to support the safe adoption of AI. And during COVID, as you'll know, there was a lot of work going on in terms of how can we get the right technologies into the right places to help us as organizations. And one of these was around COVID chest imaging. So we have a lot of AI technology companies who were doing research in other countries and wanted to work here in kind of identifying COVID as COVID from chest images. So we set up a chest imaging database, a national COVID chest imaging database. And I'm going to talk about why we set that up and then what its core activities are. But I'm not going to go into too much detail because it goes into quite a lot of like some of the considerations. But ultimately, it's a centralized database of X-rays, CTs, and MRIs. And the idea for this is, for those who are not familiar with AI, is that when you go to train an algorithm, you need to be able to have a robust enough data set to statistically be relevant, to make sure that your data is robust, to make sure your algorithm is robust enough. And also, we need to figure out a mechanism so that we can independently verify whether your technology does what it says on the tin. And we would do that through a validation data set. That's basically what we've set up. We set up this database to address that, and we're doing an ongoing data collection exercise during this pandemic. And ultimately, it's all around producing not only just research, but the ability for algorithms to be trained and applied to the applicable use cases for the clinical setting that needs to be.
Oh my God.
Was that a question? Nope. Does that make sense at this point as to why we're doing this? Yeah. And what kind of things can we do with this? So we can develop imaging processing software, so determining risk scores from X-rays. We can do mathematical models to determine whether, at the start of this could we be able to predict whether someone needed a ventilator when they come in and had a scan, and can we do other validation for imaging algorithms that we need to independently verify whether they actually work, specifically used on UK data sets. So you'll know that a lot of companies will go out and get data sets from, America, China, and others. How do we make sure that they are robust enough on our UK population? And that's what we're doing here. We've gone through we've got ethical approval for our database. We're using legislation that allows us to collect this information at this point in time. And we've also have endorsements from the relevant people who've been very supportive in this exercise. And we are in partnership with the British Society of Thoracic Imaging, other people from the Royal College of Radiologists, other imaging programs like NCCID and others have been very supportive in advising us on how we make sure that this is robust. And for those that want access to the data, we have a data access committee. So if you wanted to go and do some stuff, you're welcome to connect with us on that. You know what? I think I'll share these slides afterwards because I think there's quite a lot of detail in these. I'm conscious of time, and I think it's probably worthwhile maybe having some questions rather than just going through how a database works. And does that help? I see people nodding. Go for it.
Yeah, that's a really interesting overview. Thank you. So anybody want to unmute or post some questions in the chat? Okay. We had some questions submitted ahead of time. So one of the questions was about how do you measure outcomes as perceived by patients and staff?
Outcomes are going to be your standard clinical outcomes. This is about clinical practice, and not replacing that clinical practice. So if you take, for example, the work on medical imaging, if we were to do stuff in being able to support diagnostics, for example, or be able to detect a lung nodule detection or pneumonia, it's all about supporting that. The clinical outcomes are still part of that pathway. What we're trying to do is enhance the mechanisms to support the clinician to do their job well. Does that make sense? Sometimes I realize I might talk in gobbledygook, so
I think from my point of view, it can help. It can facilitate the data quality, so the automation of the data collection, and like you say, it just becomes part of that part of the pathway.
Yeah.
Part of the way of monitoring health outcomes.
Yeah, and I think there's a few pillars to this, right? And let's forget the slides and the other bits, but there's a few pillars to make any of this happen, right? You need good data, and you need good quality data, and even that is in itself, a hot topic, and how we do that in itself. Then you have to look at how do you, is there no biases in the data sets that you're learning from, and how do you then train algorithms on those data sets, and where are those data sets coming from? Are they coming from regional areas? Are they coming from international? Live questions. And then you have to find a mechanism to ultimately validate whether the algorithm technically does what it says on the tin. So does it meet a sensitivity and specificity that you would agree to in terms of for its use case that you're happy with? And then you've got the other mechanism, which is how do you then produce the evidence that the algorithm doesn't have an adverse effect in the clinical pathway or in any kind of decision making. And I know there's people here from human factors and others. It's very much that, like, how do you make sure that the algorithm doesn't have any adverse effects? And that's standard tech deployment. It's not even just AI. And then you've got the kind of two bits to this, which I think are, so you can verify that an algorithm does what it says in the tin, and you can go through the regulatory approvals for that, and we can support some of the mechanisms to do it. The other bit then is, well, great. Well, how do you then deploy this back in? So you can spend some time building models, but the two complicated bits are how do you then build the architecture to deploy those models back into a clinical pathway that is safe to do so? And how do you then build out the post-market surveillance? So if you've got medical health research, got the yellow card scheme, you got the CQC doing their work as well. How do you build in post-market surveillance in the use of the algorithm, and how do you audit its support in decision making? And they're the kind of things that we're looking to think about in terms of the medical imaging work. So we might open up more questions, but yeah.
We've received a question from Andrew Baker about. Do you want to speak, Andrew?
Yeah, sorry, I can speak. It's absolutely fine. Yeah. So hi Dom. My question was, I guess I'm just sort of curious as to what quantity of imaging data you might need to have gathered in order to sort of train one of these AIs to generate the model, so it could be sort of considered sufficient. So the degree of error was sufficient, presumably, that it was coming out with reliable results.
Yeah, this is for anybody that works in any form of deep learning. This is how long is a piece of string, really. So, actually, people nodding there, and so we have a database, and maybe I should be more explicit. Like this database was stood up to slow down a conversation about technology companies who are promising their wares, right? So let's and make sure that the any algorithms that were used, people were, let's go back in time, right? People were saying they could solve the panacea of all our problems with algorithms, but how do you do that? So one way we need to do that is by building a data set. That data set at this time is still live and growing. We are keeping 50% of that data back at this point for sampling, so that we can make sure that we can check whether, when you've come and done some research on it, is it actually statistically relevant? We have a few thousand patients in there. It's continually growing. Part of the issues are around actually getting the data. You know, we started out as a manual process. We're trying to automate some of this. I know that's kind of a politician's bureaucratic answer in terms of, you know, how long to piece of string. But, you know, the more data, the better, which is always this kind of ongoing conversation about, you know, statistical relevance and how do you have a robust enough data set.
So that sounds like that data set is constantly being refined. Is that correct?
That's correct, yeah. So we are at this time still collecting data from, we've got 17 trusts. I think it's about 80 hospitals sending us data. Obviously, we would like more. So if you are connected into any hospitals that are not sharing data with us, we would love to figure out a mechanism to make sure that we can. This is also helpful for wider research. And what we've discovered just in serendipitousness really is that like there is other medical imaging programs happening across the country, but from a national perspective, like how do we support this mechanism to enable research? So other stuff that's happening around ethnicity and you know, ongoing conversations about how do you know, what happens in the future around coronaviruses, etc. So does that help?
It does. Thank you.
So we've also got a question from Jorgen.
Yep.
Are any common data models adopted? For example, OMOP, OHDSI. I'm not sure if those acronyms are pronounced differently. I don't know if Jorgen or Dominic, you want to give just a layman.
Does Jorgen want to unmute and kind of talk? Then we can have a chat about this, because I think.
Yeah. So I'm just because you're saying you get data from several different sources, and sort of we're all aware of how the variety of different ways in which different data sets are recorded and implemented. So before you plug them into your algorithms, I just wondered whether you have implemented any of the common data models, or you have your own sort of standards that you work to.
So in imaging, there are a number of standards. And this goes back to that first bit of the conversation. I think it's a whole conversation itself, which is around data quality and interoperability between multiple sets. So when you've got organizations sharing data, this is an ongoing battle. We are not using a specific standard. We're obviously using DICOM as the imaging standard. And we're also collecting data sets, clinical data points in a standard as well. But this is, once I said, this was built quite quickly over a COVID pandemic, and this is where we're slowing down to say, well, what is the next steps for this, and how do we make sure that we're building out for the future? But happy to pick that up more if you want, or if anybody else wants to come in, anybody else that works in a hospital or wants to pick this conversation up, I'm happy to hear thoughts. See a few nods. Maybe everybody's shy. Any comments from anybody else? You look, let's take on standards as a prime example, right? Standards is a whole subject in itself, and standardization, and that's before we even talk about interoperability. So we're aware of this, and the people who are going to build algorithms are aware of this as well. And I think that's probably what we could say at this point. And you know, if at some point we need to set further standards, then we have the opportunity to do that. And that could even be in the deployment mechanism, like how do you deploy an algorithm that meets a standard?
We've had a few questions from Ben Taylor.
I love it. Okay, what's Ben saying? Go for it, Ben.
So one of the ones was, so the first one was, are there other national data sets available? I mean, if so, are those actually available for trust for research purposes?
So our database is available for research. We've got ethical approval for that. And there are other, like NIHR has other research programs ongoing, as others will be aware. Does that answer your question? I don't know if it, Yeah, and if you want access to this in terms of training your own algorithms, we have a mechanism for this, which is quite a tight governance process in terms of data access. So we don't just hand this out to everybody. There's a governance structure for this to make sure that we are sharing this appropriately.
Yeah, fair enough.
Yeah, and this ties into much wider conversations about like training research environments. All the kind of under the hood nitty gritty bits on. Always, Angela, good to see you. Go on, Ben.
So for the COVID radiology data, has somebody already pre-standardized these images? In other words, scaled, clipped, and reoriented them. So are they kind of ready for research, or is there? I mean, because it doesn't make any sense for lots of people to do pre-processing. If that's a centralized thing, that would seem to make sense to me.
At this point, we're just pulling them into a bucket and opening that up. So, and I think cost versus money versus time versus priorities. This was built on a shoestring. I think I'm quite proud to say that. So we've had a lot of support from people who are. And I give all my credit to BSTI, the British Society of Thoracic Imaging, and their advice, and people from the Royal College of Radiologists, and specifically the Royal Surrey, who've been very helpful in just kind of getting us started on this. But what it has done, Ben, for your benefit, is open up a more nuanced conversation about these type of things, like what is our role in this, and how do we, I did not wake up to join NHSX to build data sets. Let's be explicit.
But if it's a job that needs to be done, it's probably worthwhile doing it centrally rather than having lots of people do it. The other question I had was, I mean, why keep 50% of the data back? I mean, proper machine learning practice suggests that you should do some cross-validation and other tests. I mean, is it a trust issue? I mean, the more data we have, the more power, statistical power.
Yeah, 50% was 50% was a decision because we weren't sure how much data we were going to get, and we wanted to keep quite a. And this gets into, we're getting into an academic conversation here, but because we're real-time sampling, so this is, which I said needs to be a paper in itself. Like normally when you do research, you've got a data set that you can come back to and it's archived. For our case, we're pulling data in real time and making sure there's no biases in it. It's quite difficult. So we've decided to keep 50% back at this given time. But validation in itself, we have not at this point validated any algorithms. So we are, happy to pick us up separately, Ben. I would love your advice on how to make it happen, and others as well. Like this is, yeah. Look, environmental, social sustainabilities. I saw some papers come out this week or last week about the cost of AI and the carbon footprint. I don't have a direct answer for that at the moment, but I have made a note of it for myself and kind of research work as to how we address this issue. I don't have a direct answer. If you have ideas, I think this is why I want this to be a conversation. If you have ideas, Ben, I'm happy to hear how we might do that. And it might cost what. Yeah.
I don't have any really good ideas, but I saw like a kind of rule of thumb tool that's been published. I can send you a link to it a bit later, and that gives some kind of basic energy info for machine learning processes. So that could be useful. I met with some academics yesterday as well who are looking into this area, so I could link to that.
Yeah, I would love that, and I think it's a live question, right? It's a research question. How do we do this, and then the cost, the ROI on this, and not just the carbon footprint, but the ROI on.
Yeah, I mean, one of the key questions for me is, are there pre-existing algorithms that could do the work, or are we actually going to have to machine learn new ones? Because that's where the energy intensive bit is in training the algorithms, isn't it?
Yeah.
Okay.
I don't have a direct answer for you at this point. But
no, it's going to be case by case anyway. But it's just having it on the.
Unless you want me to give the answer, and but I don't have a direct answer. So let's. I think this is why I framed this as a conversation. I don't have all the answers. I'm just Dom. Right? I'm a cog in a wheel trying to move the conversation along. And this is all about, Matthew and I have talked about this for many years. This is all about collaboration, having conversations, getting the lessons learned from other people who have deep expertise in the various fields, so that we can enable it. I'm just in a very fortunate position where I can make some stuff happen, but I can't do it. I can't do it on my own. And so if people have these questions, and I pick up these things on human factors as well and other bits, we have a great advisory board and an advisory group that are helping us address some of these issues. We have just started. I would be explicit on that. We have just started on this. I know there's lots of research. I think it's about implementing it in the real. We've spent a lot of time academically thinking these things through. And if I kind of wind back a little bit again, like if you think of AI as a whole and healthcare, like it's such a broad subject. Like, what do you actually define as AI, and what do you find as robotic process automation? Or it gets quite. It's a Venn diagram of multiple Venn diagrams before we start talking about ML and data science and the Venn diagram of that itself. And what my approach to this is, how do we make this concrete enough to have that type of conversation, the conversation that we want to have? So, we talk about algorithms that are unexplainable, or my challenge on some of this is, what about the algorithms that are explainable? Like, how do we get those implemented appropriately and safely? And how do we learn from that and take lessons, from other places? So I'm, very much consistently in listening mode.
That's a really good point about the environment and social sustainability, and it's something that I hadn't thought about. And I was at the Digital Academy, and that's something that was never mentioned there. So, be really interested to see those papers. So if that's something you could pass on, and we'll post it onto the digital group. We've had a few questions from Vishnu. Vishnu, are you able to unmute?
Hi.
If not, okay, hi.
Hi. First time I'm using Zoom, so I'm pretty used to it. Good morning, all. That's a fascinating presentation. With regards to the COVID imaging data set, what is the clinical outcome data that is available corresponding to these images? We have the clinical outcome data we have in
So Vishnu, you're a little bit quiet.
Can you hear me now?
Oh,
perfect.
Right, okay.
Perfect.
I thought it was my laptop mic that was connected to Zoom. No, it's not. It's my speech mic, which was flying low. It's a fascinating presentation. Thank you very much for that. My specific question is about the NCCID data set.
Sure.
So you have the images, I believe. What outcome data do you have, or clinical data do you have corresponding to these images? So if we are going to train any models, what are we going to train the models against?
So I'm not going to go through the entire every single.
So the question was more of, is there outcome data, and is there reasonably very diverse outcome data, so we can measure, we can train AI to predict a variety of outcomes?
So the short answer to that is yes. I'll get the link now in a second and put it into the chat box so people can see it. There is there is protocols and everything in terms of what we're collecting, where there might be data linkages and others. Our ground truth is the PCR test at this point. But yeah, that's kind of, happy to share that with you. That's kind of, if you want a more robust conversation about the actual data points themselves.
Can I ask a very quick follow-up question?
You can ask as many as you want.
Is it possible to link this data set to the HES or the CHEST data set, which contain a lot more information?
Potentially, yes. Obviously, a lot of this comes down to IG. So linking more data sets gets quite complicated. I'm trying to make sure that we are ethical and that we have the right mechanisms and the reasons to do that. And that is an ongoing conversation. We are in unprecedented times, which has allowed us to have the legal basis for data collection for this exercise. I think if it wasn't any other time, it'd be very difficult for me to do this. That's probably the long-winded answer. The answer is yes, but and we are potentially linking to other data sets like ISARIC and others if you're interested in other research databases, and ongoing conversations with longitudinal studies, and NIHR have another research study called FOSS-COVID that they're starting, and where they'll be using our data sets for the imaging specifically. But I think one of the things that fascinated me was that nobody was thinking about images. Everybody was thinking about clinical data sets, and then well, from where we saw it in the world with the work with BSTI.
Thank you.
Does that help?
Absolutely. I think the last point you made, I suspect, from a clinician's perspective, that is the most important point, which is at the time nobody thought, and that's precisely the point, because at the moment we do not know what to expect.
Nope.
What's going to come in a few months' time. This is a very new disease. And as more information becomes available, we go, oh, we wish we had that information. We wish we knew what we can do now. And to think in terms of in the old way, which is what is your hypothesis and what is the data you need for that hypothesis, and let us only collect that data. I think that paradigm needs to shift a little bit to say, well, we need to have as much data as possible so that when we get a curveball in 6 months' time, we are prepared. I think that's the paradigm shift we need. Medicine, unfortunately, most of the domains of academia will do that. What they call it, heuristics. But you speak of heuristics in medicine, people go, don't go data fishing, don't go fishing for p-values. It's almost frowned upon. And if you're not looking, if you don't know what you're looking for, if you don't even know what questions you're going to ask, then you won't get the answers, because on this whole thing of have a hypothesis before you test, that's very good, but then that assumes that you know what you're looking for, and so what the work you're doing is incredibly important. So congratulations.
Thank you. And I think, look, this is exactly the thing, right? When I talk to colleagues who are not familiar with AI as a whole, like the concept of or just even data access, right, is there's a misconception that you can just go and get access to lots of data and just lick your finger and stick it in the air and think that you might be able to do whatever you want to do. Like, we can't do that. And there's good reasons for that. And let's not be naive, right? This is patient identifiable information at a point at time. So it's a very live question, and yeah, I think that's enough for me to say at this point. But this is what I would like your support on, and colleagues in this room, is just how do we have this conversation for the good that we want? Like, this is about building algorithms that can help us at a time of crisis, and then ideally in kind of the recovery mode of whatever else clinical activities. And I'm talking about imaging, but there's a whole lot of work around back end activities and triaging or whatever
could I just
booking.
Yeah,
go on.
Yeah, sorry. In terms of support, now I'm not sure exactly where in England you're based. I'm the ACIO. Well, I'm a consultant surgeon, but I'm also the Associate Clinical Information Officer for Data Science at my trust. The title aside, I was at a data science network meeting yesterday, and there were plenty of data scientists embedded in other NHS organizations in the region. But what they thought was really good was that also Lancashire Teaching Hospitals has funding to fund a clinician to lead on data science. That's fascinating, because we are struggling to do that. So there's the good thing, the point I'm trying to make is the good thing about the trust that I work for is that they have this vision that machine learning AI is here to stay, and we need people working on it from now. What we would like to do is to have the ability to. That's why I remember seeing Ben. So. Yes, I remember seeing Ben. Ben, you were with someone else. I think there were two of you on the screen yesterday. So I think what we would like to do is I really would like, the Northwest, the Northwest, to work closely with, the rest of the country. I know there's a lot of focus on Oxbridge and Imperial and, down south around London, but there are some pretty good teams. You should, the quality of presentations yesterday was pretty good. So we would like to work closely with NHSX. So I'm open for conversations after this meeting. Just ping me an email, or I'll send you an email, and we can continue how we can work together.
Absolutely. And the only comment I'll make to that is, I've been saying to a lot of people, it's a collaboration of collaborations. We do, there's pockets of good work happening, and this is like my role is to help bring some of that together so that we can do it at scale, or at least support some of the wider national objectives that we need for building out, for me selfishly, like building out safe algorithms. But I do not disagree with you. I live in Birmingham, but my role covers everywhere. So happy to pick up.
Dom, can I ask a follow-up question to that? Because
I just want to second that comment by Vishnu, actually. I think it's, oh, sorry.
I think we might be about to say similar things, but I thought Vishnu just made some really good comments. It's Mark here.
Mark, how are you?
Yeah, good. It's interesting to hear you talk and sort of how this sort of is shaping up. If I ask a question that's sort of slightly broad beyond imaging and that side
yeah,
of it all.
And apologies, I'm just imaging on the brain at the moment, so.
No, and understandable too. So my question though kind of links into it though, in how do you evaluate or consider which things to run with AI lab between, I don't know, some NLP over there, some imaging over there, and kind of determine what the impact of them could be. And when all these different AI solutions are just massively different, the one that I'm particularly interested in with NLP is patient social listening, and what you learn from patients out there digitally about what they're saying. And it's sort of the Cumberledge report last week, back to the Francis inquiry, or 10 or so years ago, have always been asking for better patient voice, clearer, quicker. And we think AI's got a really good role to play in all of that. And it can work in COVID, it could work in a whole raft of different ways. But how does anyone really measure up how important is that versus something else? Because there's a lot of very worthy things out there that people are trying to make developments to. And I suppose it becomes a very crowded space. And we as a small SME, we're struggling alongside a lot of others to be heard and to sort of get that consideration time. So wonder what your thoughts are about sort of how all these things sort of measure up together, Dom, and any thoughts or tips you might have on people trying to bring it to life and scale it up to another level.
With great difficulty. Is the short answer to that. The award itself has and the reason the award exists, the NHS AI award exists, is to fund some of that. So if you have a technology that you think is appropriate and helps deliver some of the stuff in the 10-year plan, and has a mechanism to do that, then there's quite a robust mechanism for going through that process, like you would for any kind of funding. If your question is like, how do you prioritize? Generically, for me, it's quite hard to do, because this goes back to my earlier comment. AI, it's like saying science, right? Like how do you use science in healthcare? And then how do you regulate science? And it's quite difficult to do unless you get into the weeds. So, and you're talking about using NLP. That's an explicit use case which has a number of components around it as to, how, why, what's the legality, all those kind of fundamental issues. And that's the same thing that I've got on imaging. Imaging is a mechanism, because there's when we've done some market intelligence, we identified there's quite a lot of companies that can offer solutions, companies, researching groups, who can offer solutions in the medical imaging field. And that's in our Get It Right report. Which is why I've thought to myself, well, how do we enable this bit on creating data verification sets? Like, how do we validate whether an algorithm works or not? And that would be my approach. How you scale up your company, I think that's the holy grail of everybody that is in this room. People like Health Foundation and others. are consistently asking this question, not just in technology, but generically, how do you scale up any idea? If I knew that answer, I would not be sat in my garage. But happy to pick up a conversation with you, Mark, separately. I think
yeah, no, Dom, it'd be good to do that, but it's good to know maybe when at least we're not missing anything obvious, at least.
Yeah, and I think it's just speaking to organizations that want to use the technology and finding the right mechanism for that.
Yeah.
So we've got a question from Mark Sujan and then Christopher Barber. And Christopher, if you could just give a brief one-line description of human factors when we get to you, that would be great. So over to you, Mark.
Right, thank you. I'm quite interested, to hear your perspective on who has actually expertise to evaluate AI technologies. And I'm particularly interested where you see the role of NHSX, I suppose, for example, with relation to MHRA. So once we leave the European Union, MHRA will kind of lose their comfortable position of being able to hide behind the medical devices regulations, and they will become, or need to become, much more active. So I'm just wondering, do you see them having sufficient expertise, or are you going to supply that expertise, or is NHSX kind of, I'm not quite sure, what is your role and where is the expertise going to come from?
I don't have an answer for that, unfortunately, for you, Mark. I think it's a good question. I'm not privy to those conversations. It's the politest thing to say. I don't know how else to expand on that, really. I think.
But do you see a role for NHSX, for example, like taking leadership there and becoming active?
So we do have an active leadership role. So when we set up our regulatory work around AI, we are the policy team that leads on this. But ultimately, it's down to the individual regulatory bodies that have the legislative piece to do the work that they need to do. I'm sorry, I can't be any clearer. Like that's, I'm happy for others to jump in. I'm happy to have a debate about it. I don't have there's no answer to this. Unfortunately, it's MHRA's responsibility to own medical device regulation.
Right. Okay, thank you. I'll chase them down.
No worries. I guess probably what is it that you wanted to know, Mark? Are you trying to get a technology validated, or?
No, I mean, I was just thinking more about the regulatory approach and where the expertise really comes from, because I'm not quite sure how large NHSX is, but as you are taking a very active approach, whether you would, for example, be something like currently the competent bodies, which we have, I think, just one left. Yeah.
So we are working with the regulatory bodies to support them in how they identify that. Like our role is, so I should be explicit. I work for the AI lab. NHSX in itself is a wider organization with a lot of other policy mandates. So from an AI perspective, we are working with the regulatory bodies to help clarify that landscape. And if you're interested in a regulatory conversation, I would highly recommend colleagues going and having a chat to Reform. Did an exercise where they mapped out the entire regulatory landscape for digital health technologies. We talk about AI, but it's digital health technologies with how do you get that implemented? They're running a virtual hackathon on this regulatory conversation. And if you're interested in that, by all means, join it. But in terms of wider national policy, I don't have an answer for that, unfortunately. Good question, though.
Also, Mark, there's a really good diagram, which I think was from Reform in the AI book, that document that Dom shared earlier in the talk. over to Christopher, if you're able to unmute.
Yeah, I'm here. There's a few of us on the call from the Chartered Institute of Ergonomics and Human Factors. Hello.
Welcome.
And Rachel wanted a one-sentence definition of human factors. Okay.
Yeah,
so,
it's like saying, what's AI?
Well, we're interested in the relationship between people and technology. I could put it that way. And in particular, I guess I've written an essay rather than a question. But my point would be, how do you ensure that the people who are going to be affected by the output of AI understand sufficiently what it's doing, both in terms of how things like different meta parameters or hyperparameters might influence the sensitivity and specificity of a result, or in terms of how data labeling, and I guess this links back to what Krishna was saying earlier, that if you can understand the purpose of the data, perhaps you could label the data more appropriately, and fitting that in with a broader clinical pathway within medical settings. I realise is way beyond the scope of and the time that you have to do anything, but these are the sort of concerns that we have from a human factors community.
I think you've answered the question in your question, and I think there's we have bodies that do evidence, that support what evidence might look like, and that's part of how you take AI out of this and just take it as health tech or take it as medicine. You need to create the right evidence and be able to identify what are the issues when you implement it. I'm oversimplifying it on purpose. Unintended consequences of using anything novel or new are things that need to be measured. And that is part of your real world evaluation and real world evidence creation. So before you would want to create, and this kind of goes back to the kind of rough 5 pillars that I have in my head. Once you've got the data, once you've trained it, once you've validated it technically, there's the other component, which is evaluation. And I think human factors, if I understand it correctly, sits in the evaluation piece. Like, how do you evaluate the unintended consequences of using this decision support tool in your workflow? And that happens today anyway. That's part of your, if you're going to use technology or adopt it inside your organization, that's a requirement on you as an organization to make sure that you see enough evidence that it's appropriate for it to use. What we would like to do, and what I think part of my role is to look at, like, what does that look like as some form of standard in some areas, and how can we help organizations who are overstretched and overburdened to consistently go out and create all the evidence or understand the evidence. And not every organization has the privilege of having data scientists inside them. So does that help? I'm happy to kind of expand further if I'm unclear. It's
No,
clarity is my learning objective. So
it makes a lot of sense, and I think the difference between clinical pathways and medicine in general and AI in particular is that there is still the sense in which AI is a magic technology for many people. It's magic and monolithic, so people don't understand the nuances between different algorithms, and they don't understand why it doesn't always give perfect results.
Yeah, I think other people on this call have better expertise in this, but ultimately we're saying the same thing. AI is a misnomer in some respects. Like, we're talking about technology solutions that help support decision making or flow of information, and it's complex, right? It's like, how do you do this as a single swoop? You can't. You need to be specific in your use case, and it'll be dependent on every organization and everybody that uses it. So, does that help?
Yeah, very much so. I mean, I think it's Ben Taylor has just said that some of these things are open research questions.
Yeah.
I'm an academic. I work at University of Birmingham, so I'm always asking open questions.
I think that's part of it, right? Like some of it, and this is where it gets, so I guess where my brain's at, and I think I alluded to this earlier, was that we end up in a conversation about what about algorithms that make all our decisions for us and the human is not there. My question at the moment is, how do we get algorithms that help the human make better judgment decisions and make sure that they're not, like they still have the ability to make an informed decision? And, you know, if you were to break it down in terms of who's responsible for that, you know, we are helping, it'll be the General Medical Council, right? If it was taking a radiological approach to it. We're just trying to help create, let's even make it simpler, right? Like statistical modeling. How do you get a statistical modeling and be able to infer something from it into a clinical pathway? And you can make a judgment call on, you know, whether you think that inference is worth looking at. Like, how do you do that? I think once we get some of that right, not to say that people aren't getting it right, how do we get that right at scale? Then we can have the stuff, which I think is really interesting, like the other wider research questions. But they are, in some cases, still research questions, I think, as someone has said there, Ben said,
Okay, so thanks, Dom, for a fascinating talk. I think we've come to the end of our time and covered a lot of areas. So on behalf of the QSIG Digital Group, a really big thanks to you and to everyone that's participated, spoken, and in the chat. And if you don't already belong to the QSIG Digital Group, please consider joining. I think in the chat we've already got the link up for that. So I think all that remains to be said is a really big thank you to everyone participating in this.
I would just like to say I am an open book, probably too much so. So if you have any questions, you can find me on Twitter, email me. I welcome collaboration. It's the only way to make any of this happen. And I am I don't know everything, so I using quality improvement as best I can.